Good morning. My name is Padma, and I'm a consultant pathologist at the Subang Jaya Medical Center, Subang Jaya, Malaysia. Now, lung cancer is one of the most common cancers in Malaysia, and it accounts for roughly about 10% of all malignancies. It is the most common cancer-related, it is among the most common cause of cancer-related deaths, and nearly 90% of our patients present late either in stage 3 or stage 4. Now, the way we think about lung cancer has changed, and we now know that lung cancer is not one disease, but multiple diseases comprising of several molecular subgroups, each of them distinguished by unique driver mutations. And these driver mutations are critically important, as available targeted therapies can achieve significant, sometimes even dramatic responses and prolonged disease control. Today, I would like to share with you our experience in molecular testing of non-small cell lung cancer and how we transitioned from single to multi-gene testing for non-small cell lung cancer in our center. This next slide highlights where I work. It's a drone view of the Subang Jaya Medical Center, which is a 393-bed tertiary care hospital located just outside Kuala Lumpur. To start off, I thought I would discuss briefly the current practice in the management of advanced and metastatic non-small cell lung cancer in Malaysia. Now, testing for driver mutations up till now in our center has always been done in a serial and stepwise manner, in part because of the high EGFR mutation rate in our population. EGFR mutation negative tumors are then subsequently tested for other potential drivers such as L-cross, BRAF, and so on. Now, things have changed because there has been rapid development in the discovery of new biomarkers. And we are also faced with the challenges of having to provide this critical information from exceedingly small biopsies, because many of our patients either have only cytological samples for analysis or small core biopsies. Lung resections are very rare in our environment. There's also a need to dramatically improve turnaround times. So when we are saddled with this problem of trying to give maximum information about the availability of multiple driver mutations and having to work with very small samples, it sort of forced us to rethink the way we do our business and our way we actually manage our workflow. So the move towards multigene testing was also accelerated by the fact that we formulated and published our own Malaysian molecular testing consensus guidelines. These guidelines then served as a backdrop and a useful roadmap evolving our strategies for multigene testing. So with the help of our diagnostic and pharma partners, the Nexus initiative was conceived to explore the best way forward. And today I want to share with you the lessons learned from this initiative. Now, this slide shows the heterogeneity of EGFR positivity among different populations, and it highlights a comparatively higher rate of EGFR mutation positivity in Asian populations. In one of the earlier publications, the incidence of EGFR mutation for non-small cell lung cancer back in 2012 demonstrated the higher prevalence of EGFR mutation in the Asian population. And this stretching from South to North Asia, the figures varied from 40 to 60%, but there was a clear distinction between Asian and Western populations. The data also showed a slightly higher risk in female patients who are non-smokers. Our own published data shows an EGFR positivity rate of about 39.5% in the Malaysian population. This next slide highlights that over the last 10 years or so, with advances in molecular genetics, we are able to profile the genetic makeup of non-small cell lung cancer patients. The figure on the left is a slightly outdated genetic profile of about 200 adenocarcinoma patients of a study conducted in Korea. And on the right side of this slide is a simple roadmap of the kind of advances that we've made in the treatment of non-small cell lung cancer. From as early as 2004, with the identification of EGFR sensitizing mutations in lung adenocarcinoma, and the way we have been using targeted therapy to manage these patients has helped improve the quality of life, and in some instances prolonged the survival of these patients. Over time, the development of ALK-sensitive tyrosine kinase inhibitors, and today the progress has reached a point when we have third-generation tyrosine kinase inhibitors available for ALK. And in the recent years, there's also been a series of immuno-oncology treatment options which have been approved. So the landscape is changing quickly, and there was an urgent need for us to keep abreast, to do the correct things, and to help benefit the patients in the best way possible. This next slide highlights the growing list of targetable therapies, and it has provided the clinician with an arsenal of treatment options with marked improved overall survival, which was shared recently in an annual oncology meeting. So we have adenocarcinomas on the left side and squamous cell carcinomas on the right-hand side. And in the purple column, we have driver mutations and their targets and targeted therapies, and with potential tyrosine kinase inhibitors which may be deployed for these various genetic aberrations. We also have below that a pink column which highlights treatments and therapies available for patients who develop resistance, and these are therapies available in the second line. So also listed right at the bottom of the page are emerging biomarkers, and these include MET, RAT, HER2 mutations, and also tumor mutational burdens. So recent meetings have also flagged out some novel markers and treatment options, including the detection of NRG1 fusions for the use of afatinib, EGFR exon 20 insertions, and these have always been a problem because they tend to confer relative resistance to TKIs. And the EGFR exon 20 insertions are fairly common, in fact, the third most common alteration in EGFR. And of course, there's been heightened activity on the use of drugs which target KRAS mutations, and this has been a target that has eluded us for some time. This next slide sort of summarizes the kind of therapies that are available, the emerging new therapies for non-small cell lung cancer, EGFR insertion 20 mutations, RAT fusion mutations, MET exon skipping mutations, NTRK, ROS, HER2, KRAS, G12C mutations, either accompanied with LKB1 mutations or KRAS mutations alone. So the problem of the small biopsies continues to dog us, and this is a statement from the IASLC and some recommendations on the use of liquid biopsy for advanced non-small cell lung cancer. Tissue still remains the gold standard, and where available, tissue is analyzed, preferably using a multigene panel with PD-L1 testing thrown in as well, should a driver mutation not be detected. And there is now a very powerful argument to be made for using liquid biopsies. Again, these can be tested using deep sequencing, next generation sequencing, with the caveat that if one is not able to detect a driver mutation with liquid biopsies, then the correct thing to do would be to reflex to tissue biopsies. And this algorithm summarizes the approach that we've been developing. So these are the molecular testing guidelines for Malaysia, and these consensus guidelines were developed with experts, pathologists, oncologists, respiratory physicians, and it represents a consensus or agreement among experts with regard to how we may approach the diagnosis and the treatment of a disease, in this particular instance, non-small cell lung cancer. And applying this kind of evidence to clinical practice is, we believe, a requirement for best patient care. It's an integral part of evidence-based medicine, not only in individual and institutional clinical practices, but also is interesting for governments and payers to want to know. So the summary of the findings are listed on the lower right, So the key biomarkers such as EGFR mutation, ALK and ROS rearrangements are considered standard of care in the Malaysian guidelines, and these are tested. And where possible, multi-gene sequencing panels are preferred over single gene testing. And we always need to be alive to the fact that the quality of the test is a key consideration, and the guidelines insist on robust in-house validation as well as external accreditation using external QA programs. So when we decided that we were going to proceed with multi-gene testing in our center for first-line NSCLC, a number of issues had to be considered. These were, in fact, obstacles that needed to be cleared before implementation could be done. So deciding on an actionable target list, and we based our choices on NCCN guidelines and local guidelines, and we decided that a small actionable panel could be developed for this use. And we also included in that list other markers which we felt were evolving biomarkers or potential biomarkers. We included these in the panel because we wanted to ensure the longevity of this targeted panel. Affordability was important, and the number of health economic studies have been conducted, particularly in the US, and with regard to multi-gene testing and its cost effectiveness. And it is important to note that the affordability of this NGS panel that we evolved, was actually very palatable with practitioners in the local environment. And this is something that we were very cognizant of, because practices will vary across geographical environments, and we need to factor in logistic costs, country GDP, local testing financial models, capabilities, local testing environment considerations, and so on. So the consensus was also important. We had to get consensus between healthcare institutes and professionals to drive this initiative. And we are very thankful to pharma and diagnostic companies which were heavily involved in the development and the education of the clinicians and the healthcare providers, which allowed us to initiate this program successfully. And of course, the relevance and of the availability of treatment options, both in the private and public sector, were important considerations. So accessibility to the appropriate drugs was fundamental to the follow-up actions for the panel testing. So the Nexus study was initiated as a single-center prospective study, and we recruited 300 patients. We wanted to identify the incidence of key actionable mutations. We wanted to map out potential prognostic trends which are unique to Asian genomics. And it also provided an important learning opportunity to assess the possibility of implementing NGS multi-gene testing as a routine. And we disseminated a lot of this information with the help of pharma and diagnostic companies through CMEs. And then we took off. The panel that we devised was a limited 22 gene panel, and most of the key biomarkers were included. This is a panel that I put up for your consideration. There are some markers that are missing. Exon 14 skipping mutations and c-Met amplifications were not part of the panel, and these were addressed in a newer NGS panel that we are developing. So those exon skipping and c-Met amplification were tested as separate standalone tests outside of the 22 gene panel. So in our newer NGS panel, more targetable genes have been included with consideration of other major cancers, so that it would be like a catch-all panel for colon cancers, gastric and breast cancers. The fusion gene panel will be expanded to include things like NRG1 and NTRK2 and 3, because the current panel only includes NTRK1. So we have, up to the present time, only curated about 26 cases, and we have learned a number of things, and I'll share some of these experiences with you. This is a breakdown of the list of mutations that we were able to get from these 26 cases that we were able to curate. And at the time that this study was, that this data was collected, we were only 3 months into the study, and I admit that the data is limited. We profiled 55 cases with 26 data points that were curated. And it's interesting to note the discordances that we already picked up as a result of analyzing these tumors using next-generation sequencing. And I want to present here 2 cases. The first case 017, which is a lung cancer case which was negative for EGFR mutation on a routine qPCR. And there was a low allelic fragment on detected, relatively low allelic frequency detected on NGS. And so we escalated it to digital PCR, where again we consistently detected the mutation. And therefore we believe that this is real. For case 26, we had a stage 4 lung adenocarcinoma in a young patient, and we detected an EGFR exon 20 insertion. And this was missed on the QCR panel because that panel did not include this particular variant. And given that the allelic frequency detected in NGS was high, 44%, we actually explored confirming this insertion. It is interesting to also note that insertion 20, as I mentioned earlier, is the third most prevalent EGFR genomic alteration in Asian genomics. And the present spectrum of EGFR TKI therapies has poor efficacy against insertion 20. Most of the first, second, and third generation TKIs have not shown to have much benefit. But as I mentioned in a much earlier slide, the combination of perhaps cetuximab and afatinib and a potential candidate such as poziotinib looks promising. So this next slide shows the presence of concomitant mutations. So we have EGFR in combination with P53 or STK11. And this was interesting because this is data that we would not have otherwise been able to derive had we only limited ourselves to qPCR. So STK11 and TP53 have been reported to have prognostic significance. We also detected PIK3CA mutations, and there are contradicting reports as to its prognostic value. For STK11, it appears that mutations in exon 1 and 2 are associated with a shorter survival. And as far as the TP53 mutations are concerned, there are many studies at the moment to show that both progression-free survival and overall survival in patients who are EGFR mutated but with a concomitant TP53 mutation fare worse. So these are interesting observations, and we are only now beginning to appreciate the significance of what kind of impact they may have on the therapies that are being instituted for these patients. So I want to stop here and just leave you with some take-home messages. It's clear to us that from the Nexus initiative and some of the things that we've learned, that this is probably the way to go. The discovery of new druggable mutations and evolving guidelines and the explosive growth really of biomarker discovery and also pari passu the availability of targeted therapies has hastened the migration to multigene testing, given the challenges that we face with small biopsies, having to work with small biopsies and extract as much information as possible from them. And in our own experience, the use of a limited 22 gene panel, while it does not include things like exon skipping, net exon skipping and met amplification, we still find that it is cost effective. And it has allowed us to deploy this kind of diagnostic solutions locally rather than have samples sent overseas. We have, through the partnership with pharma and diagnostics, made it affordable. The turnaround time is acceptable to most of our oncologists. And this has to some extent removed some of the barriers to the adoption of multi-panel testing. Interestingly, also, the presence of concomitant molecular aberrations have given us food for thought and for reflection. And we need to, of course, correlate with clinical and pathological data and build a theranostic approach to how all of this information, the clinical, the pathological, and the molecular, may be integrated to provide a holistic picture of how we should manage these patients. And lastly, it has provided us a very unique learning experience. And I'm confident that at least in the Malaysian environment, this will have far-reaching implications as to how we are going to manage non-small cell lung cancer. And I will leave you with a final image of my center, again taken with a drone, a nighttime picture of the Subang Jaya Medical Center. Thank you very much.